Okay, hello everyone. So the session for this time, I'm going to talk about pharmacokinetic assessment. So by the end of this series of lectures, you will be able to first discuss the clinical relevance of pharmacokinetic concepts, apply basic pharmacokinetic principles in therapy assessments, identify the concepts and rationale for therapeutic drug monitoring, and apply pharmacokinetic principles in TDM. So in other words, I'm going to talk about the pharmacokinetics in clinical practice, how we're going to use it in your day-to-day practice, okay? So the main objective for today is to convert those like pharmacokinetic sections in drug product monographs and these pharmacokinetic equations into clinical practice. That's a simple objective for that. The session has two parts. The first part is about the pharmacokinetic concepts, absorption, distribution, metabolism, and excretion. And the second part is going to talk about the therapeutic drug monitoring, or TDM. So what's pharmacokinetics in clinical practice? So examples, like for example, what is the IV dose of morphine if my patient is currently on 10 milligrams PO morphine? So if the patient on 10 milligram oral morphine and we want to switch to the intravenous dose, equivalent dose, one of the main uses of pharmacokinetics is actually get to know what is the equivalent dose, which is the pharmacokinetic factor that you might look at. This could be the bioavailability. My patient got started on vancomycin. When do I need to measure vancomycin level? So that's another question. So, right. So do I need to measure it after the first dose, after the second dose, third dose? My patient experienced a serious adverse reaction from rivaroxaban. When it's going to be out of his system? That's another point, right? So it takes usually 3 to 5 half-lives for the drug to get out from the system. We'll talk about that later on. Do I need to load this drug? Do I need to add a loading dose? And what is the loading dose? So some drugs need a loading dose in order to reach a steady state quickly, right? We'll discuss that later. Okay, so one of the things, carbamazepine level came back at 20. What should I do? Okay, first you look at your patient and you will use TDM and pharmacokinetic concepts to make decisions. Okay. So this is just some examples of how when we use some examples of using pharmacokinetics in clinical practice. So to summarize, so it's pharmacokinetic in clinical practice used therapeutic drug monitoring to answer many clinically relevant questions. For example, the IV-PO conversion or formulation conversions or route conversions, loading dose, the time to steady state, how long it takes for the drug to be out from the system, also pharmacokinetic drug interactions, and missed doses as well. For some drug, if you miss a dose, it's not a big deal, but for other drugs, it's a big deal, right? So what's pharmacokinetics? So pharmacokinetics is what the body does to the drug, right? It is the study of the drug journey from the time of its administration to elimination, okay? And it involves absorption. So if you are giving the drug with any route or route, with the exception of IV, it needs to be absorbed to reach the bloodstream and then gets distributed into the body, right? And at the same time, it needs to be metabolized or excreted. So absorption, distribution, metabolism, and excretion. absorption, distribution, metabolism, and excretion. Sometimes we call it the ADME system. Okay? So let's talk about absorption. Okay. So when the drug is administered by any route except the intravenous route, it needs to be absorbed to reach the bloodstream, right? The fraction of the administered drug that's absorbed is called the bioavailability, or F, the extent of absorption, okay? And this depends on the characteristics of the drugs, the physicochemical characteristics of the drugs, and the absorption site as well, right? Some drugs is absorbed from the stomach, some drugs if it's given orally, and some drugs are absorbed from the intestine, right? For intravenous route, the F or bioavailability is 100%. Because it doesn't need to be absorbed, right? Because it's directly injected into the bloodstream. Do we need bioavailability in our clinical practice? Yes. As I mentioned, it helps determine the dosage when switching among different routes, IV to PO. I'll give you an example in the next slide. Also, it helps determine systemic exposure. How's that? Let's have an example. So the following table shows the bioavailability of example drugs which could be helpful in dose conversion. For example, phenytoin and valproic acid, as you see, bioavailability is 90 to 100%, almost close to 100%. So this gives us an impression that converting the IV to oral dosing, or vice versa, the daily dose conversion ratio is 1:1. Right? So for example, if the patient is getting 200 milligrams intravenous twice a day of phenytoin, what would be the equivalent oral dose? It's going to be 200 milligram PO twice a day, which is because it's close to 100%, right? On the other hand, if you look at propranolol, bioavailability is 25%. This reduced bioavailability usually it's due to the extensive first pass metabolism. The drug gets metabolized in the liver before reaching the systemic circulation. And that's why when you look at the propranolol monographs, the intravenous dose is much lower than the oral dose. As I mentioned, also bioavailability determine the systemic exposure. If you look at the vancomycin oral at the bioavailability, it's 0%. What does it mean? So if you take oral vancomycin, it will not be absorbed. It will not reach the systemic circulation. So it's not oral vancomycin cannot be used for treating systemic infections because it's not absorbed, right? Yes, it can be used for local infections, like for example the C. diff diarrhea, right? Okay, that was the bioavailability, which measures the extent of absorption. So the second concept related to absorption is a salt factor, or S, as you see here. Some drugs are available in different salt forms and prodrugs. The salt factor is also important for determining the equivalent dosages of drugs. Salt factor, it is the fraction of the prodrug or salt form that contains the pharmacologically active drug. So it's if a prodrug, once it's administered, it gets converted into the active agent, pharmacologically active agents, and this pharmacologically active agents is the one that does its actions. And so this is the important about the salt factor. Let me give you an example, okay? So again, it is important for determining the equivalent dosage of drugs. For example, phenytoin, okay? So phenytoin is available in the market as a parenteral product, parenteral, like it can be given intravenously, and also oral extended release capsules. Both the parenteral product and the extended release capsules contain the phenytoin sodium salt, okay? While the tablets and suspension. It's also available as tablets, immediate release tablets and suspension. It contains the free phenytoin acid form. Okay, so phenytoin sodium contains 92% of the free phenytoin acid form. Okay, so phenytoin sodium in the parenteral product or the oral capsule contains 92% phenytoin, free acid form. So in other words, 92%, so the salt factor is going to be 0.92. Okay. However, in this case of phenytoin, this difference is not clinically significant in most patients, and usually we use in practice 1-to-1 conversion. But this salt factor could be clinically significant, like in the case of aminophylline, right? Because it gets converted to the active theophylline, and the salt factor is 0.85, which is, or 0.8 as well. So those adjustments need to be done if you are converting from formulation to another formulation. Okay. So the third concept in absorption is the rate of absorption. And this is best reflected when we compare sustained or controlled release formulations with immediate release ones of the same drug. Okay, as shown in this figure here. So this is the time versus concentration versus time relationship, and this is the drug concentration. You have two graphs here. One is an immediate release, the blue one, as you see here, and the red one is a sustained release formulation. And this is the range here. This is the reference range or the therapeutic range. Okay. As you see, immediate release formulations release the drug rapidly. Concentration goes up quickly, with the potential for high maximum concentration. And the maximum concentration we call it Cmax, right? While the SR formulation releases the drug slowly and the Cmax will be lower, right? However, yes, the immediate release has a higher Cmax, but the effect goes away quickly because most of the drug got released already, right? If not all of the drug. But in case of sustained release, it actually stays longer inside the body, right? What's the clinical relevance of that? Rate of absorption determines the onset of effect, time to peak concentration, and in formulation conversions. Okay, let's have example. Diltiazem is one of the calcium channel blockers. The extended release formulations of diltiazem slowly release the drug in the GI tract, and generally they are administered on a once daily basis, right? There's also available the immediate release formulation, which quickly releases the drug, right? And so it will have a higher Cmax and faster onset and offset of action. But because of the fast offset of action, you need to dose it more frequently, like every 4 hours, like 4 times a day, for example. So if that's why we do not, most of the extended release formulation you cannot crush, right? Because if you crush the tablets or the beads in the capsules, the concentration will shoot up and might lead to toxicity. So if the patient is unable to swallow extended release formulation, you might need to switch to short-acting formulation if available and dose it more frequently. Are there drug interactions at the absorption site? Yes. Pharmacokinetic drug interaction can happen at any level during the drug journey in the body. Drug interaction can happen at the level of drug absorption. For example, as you see here, the co-administration of levothyroxine and iron supplements leads to reduced bioavailability of levothyroxine. As you know, like you don't need to give iron and levothyroxine together. Why? Because the levothyroxine absorption gets reduced. So if you see in this graph, shows serum TSH here, TSH, in patient on a stable dose of levothyroxine before and 12 weeks here, after co-administering ferrous sulfate in the regimen. As you can see here, the TSH increased, suggesting reduced exposure to levothyroxine. Generally, administering levothyroxine and an iron supplement should be spaced with at least 4 hours, in order to avoid this interaction. Another example is the phenytoin. Administering phenytoin with tube feeds could drastically reduce phenytoin bioavailability up to 80%, putting the patient at risk for poor seizure control. So holding tube feeds 2 hours before and 2 hours after phenytoin administration is recommended. Okay, so that's about absorption. So once a drug is absorbed, it distributes, right? And when we think about distribution, we think about volume distribution and protein binding, right? So what's the volume of distribution? So once a drug is absorbed or given intravenously, it distributes through systemic circulation to different tissues in the body. And the extent of distribution depends on the physicochemical characteristics of the drug, such as lipophilicity, tissue affinity, and protein binding. Okay? Volume of distribution is the apparent volume in which the drug distributes, right? It reflects the extent of drug distribution in the body. Drugs with high volume distribution, so if it reflects the drug distribution, so let's say drugs with high volume distribution will be distributing higher in the body as compared to drugs with low volume distribution, right? Will go to other tissues and so on, right? So is it relevant? Can be useful in our day-to-day clinical practice? The answer is yes. It's helpful in determining the loading dose. Okay, I'm going to talk about that in the next slide. Okay, let's think about it. So if you have two drugs, okay, so you have two volumes with two volume distributions, okay? So administering a loading dose of drug could be of value to rapidly attain therapeutic concentration. As you can see in this illustration, so if you add the same amount of a compound, 100 milligram, okay, into two beakers, one contains 10 liters and the other contains 100 liters. What would it give the same concentration? Of course not, right? Because if we put 100 milligram in a 10 liter, the concentration will be 10 milligram per liter. But if you put 100 milligram in 100 liters, it will give you a concentration of 1 milligram per liter, right? So therefore, drugs with higher volume distribution will require higher doses to attain similar concentrations, right? And this is the concept of the loading dose. So the loading dose is a desired C steady state, which is the steady state concentration required multiplied by the volume distribution. And if you look at the math too, like the higher the VD, the higher the loading dose, right? In order to achieve the same steady state. Other factor that also could affect volume distribution is protein binding. Drugs combine to plasma albumin, alpha acid glycoprotein, generally basic drugs, or lipoproteins. The higher the extent of protein binding, the smaller the volume distribution. Why? Because the drug binds to plasma proteins. So it's restricted into the plasma. So it's not distributing to other tissues. So the volume distribution will be small, right? Any factors or the factors that affect protein binding, like for example the concentration of plasma albumin, can alter the percentage of the free fraction, and so can alter the efficacy, clearance, and volume distribution. Why? Because now the drug is bound to plasma proteins, so there is a free and bound fractions. The free fraction is the pharmacologically active moiety, that actually goes to the site of action, does its thing, right? And also it is the fraction that gets eliminated. So when you increase the free fraction, what will happen? Efficacy might go high, even toxicity could increase. Also, clearance will be increasing, and volume distribution will be increasing because it distributes more into the tissues, right? So if the drug, when the drug is distributing into the blood systemic circulation and goes to the tissues, you can measure a drug concentration in the blood, right? And that's the idea of therapeutic drug monitoring, when you measure the concentration of the drug in the blood. So some drugs has what we call a reference range. What's a reference range? Reference range, it is the range of drug concentrations below which the drug is most probably ineffective, and above it, it's most probably toxic. Okay? It's important to say that it's called a reference range and it's not carved in stone. Okay? So what does this mean? Some patients may respond to the drug at concentration below the reference range, and some patients may develop toxicity while the concentration is within the reference range. However, it's most likely it will cover the therapeutic effect, right? So the reference range can be used as a tool rather than an ultimate target. That's an important piece here as a clinical role. You need to treat the patient, not the level. You can use the level as a tool for you in order to care for your patient, but you don't use it as an ultimate target. You need to achieve a certain number without looking at your patient. Okay, that's important things. If we can measure a drug concentration, it doesn't mean that we need to measure it, okay? Routine levels are not recommended. Only measure the drug concentration if it's indicated, okay? And we will discuss this in the later section about therapeutic drug monitoring. With regard to we also usually we measure the concentration at steady state. Okay, so at steady state, when the becomes a stable concentration, usually after 3 to 5 half-lives, usually measure concentration at steady state, when I'm going to talk about in the next video. Pre-steady state levels can be beneficial. Sometimes we need to measure pre-steady state in some situation to determine the adequacy of the dose. For example, if a patient has a really severe infection, life-threatening infection, and you are treating with an antibiotics like vancomycin that need therapeutic drug monitoring, sometimes we do pre-steady state levels to make sure it's within the reference range. Make sure it's effective. We don't want to wait for a long time in order to see if actually this drug is effective or not. Okay. With regard to drug interaction at the distribution level, protein binding displacement could contribute to drug interactions, right? Especially in drugs that are highly protein bound. Like generally when they say highly protein bound, usually protein binding is more than 80%, okay? Drugs are highly protein bound, for example, like phenytoin, for example. I will give you some examples here. So if you look at the phenytoin, vancomycin, levetiracetam, and amiodarone, okay, that's the volume distribution. First, I wanted to look at the volume of distribution of amiodarone, 66 liters per kilogram. What does this mean? This suggests that this drug has extensive distribution into the body, right? And might need a very high loading dose in order to achieve therapeutic concentrations. When you look at the phenytoin and amiodarone, the protein binding is more than 80%, like 90%, more than 96%. It's high. So we might expect that could be an interaction at the protein binding displacement, right? And actually phenytoin gets displaced by many drugs because of the high protein binding. And this can drug interactions. On the other hand, when you look at levetiracetam, its protein binding is pretty negligible. It's less than 10%. I don't expect any drug interactions at the protein binding displacement for levetiracetam. Okay? So this is how I use these numbers. So for example, if you are suspecting there could be a drug interaction here, look at the protein binding, percent protein binding in the drug monograph and see if it's actually possible or not. Okay? So now the drug is absorbed, the drug distributes and also now needs to be eliminated from the body. The drugs exit the body through either or and metabolism and or excretion, right? Excretion unchanged or metabolized. The main organ for metabolism is the liver, and the main organ for excretion is the kidney. There are other areas of metabolism in the body as well. What's clearance? So when you come to metabolism and excretion, you think about the concept clearance, okay? It is the volume of the blood cleared from the drug per unit time, okay? And the clearance, it depends on the drugs, right? It depends on the chemical properties of the drug, how it's metabolized, how it's removed, and also depends on the liver and kidney function, right? Like if you're talking liver metabolism, for example, it also depends on the drug metabolizing enzymes like the cytochrome P450s and so on. Is it relevant? Yes. It's important to determine the drug half-life and for dosage adjustment organ impairment. Okay, I'll give you an example. So if the drug is highly metabolized, like say 99% metabolized in the liver, so in case of patients with liver impairment, dosage adjustment might be needed. And at the same time, like if the drug is highly renally eliminated and in renal failure, the patient has renal failure, renal adjustment is needed, correct? So what about half-life? Okay, drug half-life is the time it takes for the drug concentration to be reduced into half, okay? Clearance and volume distribution determine drug half-life, okay? So the half-life, for example, if the concentration is 100, the time it takes for the concentration to go down at 250 is called the half-life. Half-life, it's a hybrid. It's a hybrid. It's a dependent variable that depends on the clearance and volume distribution. Okay, so let's look here. So if the clearance is increased and volume distribution remains the same, what happens to the half-life? It goes down. Why? When you think about it, the higher the clearance, the shorter time the drug will stay in the body, right? So the half-life will be shorter. On the other hand, if the clearance stays the same and volume distribution increases, the half-life will go up. Okay? Why? Because the volume distribution increases. When the volume distribution increases, the drug will be distributing all over the body, will be hiding from the elimination organs, and the half-life will be longer. But if both clearance and volume distribution increase, so clearance increase, half-life goes down, volume distribution increase, half-life goes up, this might lead to no change in the half-life. Okay? Is half-life, what's the clinical relevance of half-life? It's very relevant. So it's more easily found in drug monographs. Like drug clearance, you will not find that often. It's important to determine the time to reach a steady state. Remember that. It takes 3 to 5 half-lives for the drug to reach steady state. So knowing the half-life is very important. Drug accumulation. And also you need to know how much, like it will help you to determine how much it takes for oral drug concentration, for any drug concentration to decline if the drug gets stopped. Okay? Usually it takes around 3 to 5 half-life for the drug to get out from the system. Okay, 3 to 5 half-lives to reach a steady state, and 3 to 5 half-lives to get out from the system. An example, we have phenobarbital, for example. It has a half-life of 2 to 6 days. So if you start dosing it, it takes up to 3 weeks to reach steady state. That's an example here, like the phenobarbital really needs a loading dose to quickly attain the steady state concentration. So if you look at the metabolism and excretion here, valproic acid is extensively metabolized, okay? More than 93%. So expect dosage adjustment in liver impairment. And if you look at the gabapentin, it's 100% renally eliminated, excreted, right? And this means renal adjustment is needed in patients with kidney impairment, right? And if you look at the half-life of vancomycin, it's 8 hours. So what does this mean? So it needs 3 to 5 half-lives to reach a steady state. This is in patient with normal kidney function. So 8 hours multiplied by 3, so it needs at least 24 hours to reach a steady state. Okay, 24 hours of dosing. The most common clinically relevant drug interactions usually happen in metabolism and excretion. And there are many drugs or liver macrosomal enzyme inducers like phenytoin, carbamazepine, rifampin, and so that might have multiple interactions. And also some inhibitors could be happening, like clarithromycin, for example, is a liver macrosomal enzyme inhibitor. Also, B-glycoprotein inducers and inhibitors can affect the excretion and removal of the drug from the body. So these are important factors, and for this interaction, you might need to consult a drug interaction reference in order to see those types of interactions. So in summary of this section, so the journey of the drug in the body, pharmacokinetics, involves absorption, distribution, metabolism, and excretion. In absorption, we talked about bioavailability, salt factor, extent of absorption, and rate of absorption. Also in distribution, we talked about volume distribution, protein binding, and drug levels. And metabolism, we talked about the concept of clearance and half-life. So for further readings, there is a suggested resource in Chapter 22, Pharmacokinetic Assessment in the Patient Assessment in Clinical Pharmacy. Contains more details about what I discussed in this recorded lecture. Thank you.